Mr. Chairman. Mr. Dink, you've testified that alcohol and drug treatment funding has been cut by 25%, while requests for service have quadrupled since 2014.
Yes, sir.
Have you identified either federal or state funds that could reverse those cuts in future fiscal years?
That testimony came from one of the single county authority directors who specifically gave those statistics. There is hope that at the federal level there might be some funds that would be earmarked, additional funds that would be made available. The Cures Grant, Pennsylvania received about $26.5 million under the Cures Grant from the federal government to deal with drug addiction and treatment services. Also, the Pennsylvania General Assembly, our budgets are extremely strapped, but I know there's interest in looking at expanding treatment options. There was over $30 million provided in the state budget to set up what we're calling centers of excellence around the Commonwealth. So there has been new money provided at the federal and state levels to support treatment programs.
Well, are you fearful that the passage of the tax cut bill that is pending before Congress now will have an adverse impact on the ability of the federal government to fund these grants that have been insufficient in the past?
I really can't speak to that, sir, quite honestly, in terms of not knowing all the details of the tax cut bill. I think, priorities need to be made in terms of what works best for the nation as a whole, but quite honestly, I have not looked at the specifics of the tax cut bill.
Well, let me ask you this question.
Sure.
Do you anticipate that future health care cuts based on changes in federal health care laws and regulations, such as the repeal of the Affordable Care Act, also known as Obamacare, do you think that that could have an impact on the ability of those seeking treatment to get drug treatment?
If funds are cut serving Medicaid-eligible individuals who are in need of drug treatment, then there will be challenges that present themselves for those individuals. We have found community foundations and others stepping up to the plate and helping out in terms of providing services for indigent individuals. Time will see as to what impacts at the federal level that filter down to the state play out for those audiences, sir.
Well, thank you. Mrs. Hale, in your testimony, you state that the second pillar of addressing the opioid epidemic is treatment. Has the Affordable Care Act, also known as Obamacare, affected the ability of residents of Kentucky to get treatment for drug addiction?
Has it affected the ability? I probably can't address that properly as well.
Let me ask it this way then. Have there been opportunities for people to get treatment in Kentucky for drug abuse and drug addiction because they had access to the health care system through the Affordable Care Act and the state's expansion of Medicaid under the Affordable Care Act?
There have been opportunities. I'm sure that has resulted. One of the things that Unite did before is in providing the vouchers for people who did not qualify, did not have private insurance or Medicaid to enter long-term rehabilitation.
Well, do you worry that a withdrawal of federal resources from social services can adversely impact the ability of people to get treatment for drug abuse in Kentucky?
I think our communities are rallying, our state is rallying around to fit those needs. What I would be concerned about is if the system could handle all of that.
I know it's a political football, but we got to get away from politics and start looking at how we help people and whether or not federal policies are helping. Now, Mr. Novak, what is the historic role of the DEA in stopping the flow of suspicious drug shipments in Appalachia?
Historically, that was exactly the purview of what DEA was doing nationwide. Appalachia was especially hard hit. And the problem is the suspicious orders are to be monitored and reported by registrants. DEA has historically been, reactive, not proactive, because there are suspicious orders going into West Virginia in a town of 925 people that's getting 9 million oxycodone pills, and that's not reported to DEA. DEA then finds out about things like that and can go in and try to shut them down. But that's exactly what DEA relies on in putting together its cases and trying to have a registrant, like a distributor or a manufacturer, monitor what's going out. Unfortunately, historically, we found that they weren't, and they were just pushing orders of that size into regions with no concern of whether or not that order was suspicious.
Thank you. My time has expired.
Again,